Tourette syndrome. It's meant many things over since late 1800s when it was first identified. Initially, it was thought to be a neurologic condition, and then for a pretty long period of time, it got shifted over as a psychiatric condition, and then in the 1960s or so, it was identified again as a neurologic condition because we had treatments that really made a big difference in terms of tic severity. Then in the mid-1980s, we understood that there were all kinds of comorbid conditions that ran in families and that were really part of the syndrome, if you will. More recently, we are coming to understand that the environment has a huge impact on tic severity. And so I think, while Tourette syndrome is motor and vocal tics, our understanding of it has really evolved. And I think we're moving to a time where we really understand that it is a neurological vulnerability that runs in families, but that also is shaped by the environment and actually can be influenced by the environment in a positive way too. So some of us call it neuropsychiatric, some of us call it neurobehavioral. It's a complex condition. The majority of cases of kids with tics are mild. So estimates are up to 25% of school-age children will tic or twitch at some point during a year. Most of those kids will have their tics go away. About 10% of people with Tourette syndrome will actually have symptoms that progress or worsen into adulthood. The best estimate for the prevalence nowadays of Tourette syndrome is about 1%. So it's 10% of 1% are really going to have the most difficult course of symptoms as they move into adulthood. Mild tends to predict mild, but it depends upon when you take that snapshot. So if a child has mild symptoms when they're 13 or 14, that's probably the period of time when they should be at their peak severity. Mild symptoms when they're 6 or 7, it's kind of hard to know exactly what's going to happen when they turn 13 or 14. So it's a variable course. The vast majority of folks have mild symptoms. There are children with mild symptoms. These are motor tics where it's the intensity and the frequency of the tics, for example, really look like just an extra movement. So, for example, an eye blink, that's a normal eye blink, and then you'll see a kid who may do 3 instead of just 1. Then you'll see people who have more pronounced motor movements where their eye tics are much stronger and more powerful. Those are the kinds of movements that stick out, people notice, and people will comment upon. So you can go from that, which is the kind of simplest and most basic symptom, to something that is quite extreme. Truncal jerking, big motor movements of the body, sometimes big thrusting movements of the arm or of the legs. Those things are quite noticeable, more extreme, and appear to be associated with more disability, if you will, simply because people are uncomfortable from those movements, and they're also more noticeable to others, and so people will look at them funny or form ideas about them as a person that aren't fair. And then add to that the vocalizations. It can be as simple as a sniff or a throat clear, and can be all the way up to repeating sentences or saying words. So the range of severity is quite large. The course of symptoms from childhood to adulthood, for the vast majority of children, they're going to have mild tics and they're going to go away. Those kids may never come to clinical attention. I would hope that whoever saw those tics would screen that youngster for learning and school problems and anxiety issues, because those are the common conditions that occur with tics, even in people whose tics aren't severe or don't persist. The tics themselves will pick up steam if they hang around, and peak severity is in the teen years, early teen years, and then they tend to dissipate or improve. And some people actually will have very mild tics in adulthood. Some people have no tics at all in adulthood. About 10% of people diagnosed with Tourette syndrome will go on to have a severe case in adulthood. So for children between the ages of 12 to 16, there's a couple of issues for them. First of all, the 12 and 13-year-olds, they're right at the period of peak severity. The 15 and 16-year-olds ought to be experiencing some decrease in symptoms from that peak, if they're the average kid with Tourette. The other thing that's happening from age 12 to 16, that's when depression first begins to present itself in childhood. So one of the things that kids in my care, I'm watching them quite closely, because even though they might not have had ADHD, they might not have had any anxiety or OCD earlier, as they move into those early teenage years, that's the period of time when depression will first strike. And depression is something that appears to occur more commonly in kids with tics than other kids. And if you recognize it early and you use good evidence-based treatments, you can kind of dodge a bullet, if you will, because depression that goes untreated, teen depression is oftentimes unrecognized for the first 3 or 4 years. So if you have Tourette syndrome and you also develop a depression and that depression doesn't really get recognized, you're kind of, as an adolescent, you're doubly affected, one by the Tourette and then another by depression. So part of forming a doctor-patient relationship is getting somebody who can help you watch your youngster and make sure that those kinds of complications don't occur, and if they do occur, that you've got somebody ready to go to work and to limit the kind of impact that those conditions can have on a youngster. From my point of view, and I think other experts will agree with me, the co-occurring conditions are oftentimes more disabling than the tics themselves. So getting those identified and getting them identified correctly and then getting them treated is really important. It's amazing to me how many folks, families, young people, they start with tics in childhood, go on to develop the co-occurring conditions, but really never get their co-occurring conditions identified or treated. And yet people blame it on the Tourette, when it really isn't the Tourette. It's really the co-occurring conditions that are really affecting their functioning. Pound for pound, problem for problem, the co-occurring conditions tend to start in childhood and pick up momentum through adolescence, so that a youngster with an anxiety disorder, for example, may see their tics rise in the early teenage years and then fall, but their anxiety can pick up momentum and actually be more severe in their mid to late teenage years, especially if it's not treated. The other piece is that the treatment for ADHD, the treatment for anxiety, the treatment for depression, those treatments are very good. The outcomes are terrific. But people are afraid of labeling their kids with those conditions, and they're also afraid of the treatments. And that's sad for me, because the treatments are good and the labels actually help people understand. Just like the label for Tourette helps people understand what's going on there, the labels for the coexisting or co-occurring conditions are extremely helpful, and treatment works for those conditions. So the saddest thing I see is when somebody's gotten stuck on a Tourette diagnosis too long and they've really ignored the co-occurring conditions that are really the cause of their disability. Tics are always caused by the brain. But once you start ticking, things happen. So I think every kid with Tourette knows that if their dad sniffs at the dinner table, that kid with Tourette is going to sniff. You know, if their mom brushes hair out of their eyes, that the kid is going to put that hand up and brush hair. So we know stressful experiences will increase tics. Disneyland, which sounds like a wonderful thing for a youngster who's just made it through their first year of ticking, oftentimes Disneyland is a disaster for kids with Tourette. The excitement drives tic severity up. We also know that when kids are focusing and concentrating, I've heard some kids describe when they're in that boat fishing and they're throwing that lure and cranking it and they're not talking and they're in that mindless activity, their tics drop to nothing. So we know that there are environmental things that make tics better and make tics worse. You could imagine a youngster in a high-stress household or in an inappropriate school system over a period of years that might actually impact their lifelong tic severity. So what we're trying to do is we're trying to teach families about the kinds of things that they can do in their home, not to just reduce stress, but to improve functional capacity. We want kids not just to be in a bubble, a stress-free bubble, but we want them to have coping skills so that when stresses hit them, they know exactly what to do and the stress doesn't feed into their tic severity. We also teach them tricks. Most of the adults with Tourette syndrome that I've met anyway have all kinds of strategies that they've learned over time about how to manage their tics for social situations or work situations. And so we've developed a manual, if you will, of those strategies that adults have used. We've integrated it with the best behavioral theory, and we're now teaching kids 9 to 16 about how to manage their tics better using the strategies that adults have told us about and merging that with behavioral theory. So in one of our studies, we have really good outcomes. And again, not everybody gets better, but the kids who are able to benefit, a number of them had 30% or so reduction in their tics without changing their meds. The other piece about that is that kids are empowered by the behavioral strategies. I use medicines all the time. I love medicines. They work extremely well. But you know what? They don't empower somebody. People get better, they feel better, they can go function. But there's something about teaching people about how to manage their tics, to teach them about the psychology of tics, if you will, that puts them in control of their body in a way that they otherwise aren't, and also gives them an opportunity to move through situations more successfully than they otherwise would. That part of the behavioral treatments, I think, gets kind of lost on people. They kind of think of this as behavior modification or something like that. They don't really realize how empowering it is for a young person to be able to do something to master a symptom and manage a symptom that before was really bothersome to them. It's fun to watch kids get better in that way and hear what they have to say about it. Usually the first thing I say to people who are newly diagnosed is really to tell them what to expect going forward in the future. Because these are young families with young children, and they oftentimes have read a lot about Tourette syndrome before I ever see them. And some of the things they read aren't true or are kind of scary. So my biggest job is really to educate them about really what to expect. And the thing that seems to be most important to families is really that while the peak severity is in the early adolescent years, that for the vast majority of people, tics improve as they move into their mid to late teens. Knowing that some of the worst cases that they've seen on radio or TV are really the exceptional cases, and that the vast majority of people do pretty well as they move through their teenage years, is reassuring to families. The other thing that I talk with them about that I probably spend more time on is because these are children who have a really difficult time controlling their motor movements and the sounds they make, that I really ask families to help them work to control everything else they possibly can control. So I want them to be good students, I want them to be good citizens, I want them to be good athletes. I want them to really not focus so much on the Tourette per se, but I want them to focus on the core elements of solid identity, so that by the time they're an adult and their tics are beginning to fade, they are well-rounded adults who have been well-educated, who have good friends and have good leisure activity skills, and so that they can move into adulthood having escaped, if you will, some of the difficulties that we know kids have had in the past with Tourette. Well, I wish this was a world where everybody did the right thing all the time. But my experience is that most of the time schools do what they do, and their job is really to teach kids. And when kids who have special needs go into those school systems and they really struggle with being taught, if you will, schools need to do something to be responsive to those youngsters. But they usually don't have Tourette syndrome in their repertoire, and so oftentimes they need to be taught. And so what I talk with families about is how to form a relationship with that school and how to develop a collaboration, a true, honest collaboration, so that the school really can do the best job that they can possibly do in educating that family's child. We see lots of problems. Some of the problems are in the school, some of the problems are within the family, sometimes the collaboration never forms. And so families get frustrated and schools get frustrated. And the end effect of that frustration and lack of collaboration is the kids really get stuck. So I start real early working with families about how to work with their youngster at home, identify those things that really work in terms of keeping their child disciplined within the classroom, giving him the right attitudes about learning, and then when the parents really understand what works for their child, then to work with the school to implement those strategies at the school. When I talk to school personnel, my job is to help them feel like they want to collaborate with the family that I'm working on the behalf of. I think that makes sense. And so the thing that I do is I form an alliance with them. I model for the family how to form a collaboration. And the first thing I do is I recognize that their primary job is to educate every student in the classroom, and that they have oftentimes limited resources, they work under pressure, that there's lots of pushes and pulls, and that they're going to be asked to do something special for one particular youngster. And I want them to be agreeable to that. I don't want them to say everybody wants something special for their kid. I don't want to get into that. I want to form that collaboration early. So my educational efforts are really to try and demystify Tourette syndrome to these folks, to focus on, if you can educate this youngster and keep him busy. I think we now know that a kid who's focusing and concentrating in the classroom is ticking less. That it's a lot easier for that youngster if he's working hard and is in a positive learning environment. And that on some level, if they really do a good job teaching and that youngster gets engaged in the school environment, they shouldn't see many tics there. On the other hand, if the classroom is disruptive, if the teacher doesn't have good control of the classroom, or if the kid has a learning disability or is inattentive and needs a lot of extra support, they will likely see more tics and struggle a little bit. So I try and tell them things that they can do in the classroom that can make it easier for them to teach, but also make it easier on the youngster and make it easier for the youngster to learn. That kind of collaborative spirit really goes a long way. Demanding something from a school system, as soon as I've tried to demand, what some student is entitled to, most of the time what they do is they get bureaucratic with me. They start doing everything in writing, they start getting slower, they take their 90-day reviews. They are human beings and need to be respected in the whole process and need to be brought along. And I do it myself, and I encourage the families to take that attitude. Chocolate chip cookies, birthdays, holiday cards go a long way to getting your kid what he needs in the school classroom.